Welcome to this peer voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/pmg. This activity is supported by an educational grant from Sanofi.
Welcome to this peer voice satellite meeting entitled Individualization Requires Communication, working with our patients with newly diagnosed multiple myeloma to optimize treatment outcome. This is the faculty of the Satellite Symposium today. I'm Thanos Dimopoulos from the University of Athens, and I'm joined by Ailey Duncan, who is Head of Patient Research, Myeloma Patient Europe, Scotland, Dr. Monique Minema, Professor of Hematology from Utrecht University, and Dr. Fredrik Svendkot, Head of the Oslo Myeloma Center. And I would like to ask Ailey Duncan for her presentation.
Okay, so my name is Ailey Duncan, and I'm Head of Patient Research at Myeloma Patients Europe, and I'm delighted to be part of this discussion today. So the treatment and care of every myeloma patient is unique, but for all patients there are many decisions that need to be made, from diagnosis through relapse and beyond. And shared decision making is where the health professional and the patient work together, share information and work collaboratively, and share their expertise on both sides. So the patient leads on their life, their goals, their preferences, and the health professional obviously leads on their medical expertise. The decisions in myeloma are complex. Patients have to balance the risks and benefits along with their personal goals. And a shared decision-making approach can be beneficial. It's been shown to lead to greater patient satisfaction. It can enhance relationships through better communication and trust. And it can lead to better adherence to treatment plans, because patients who have been involved in the decision-making around treatment are more likely to be able to follow treatment as intended. And through this, it can lead to improved health outcomes. So at MPE, we did some research to understand better how decision-making is happening for myeloma patients across Europe and what some of the barriers might be. So we did this research in collaboration with the University of KU Leuven, and it had two phases. So in our interview phase, we had 36 patients from 9 countries and 20 health professionals from 5 countries. And this was then followed by an online survey that reached more than 550 patients from 21 countries and 89 health professionals. So I'm going to share some of the key findings from this research. We found that there was a significant knowledge gap. So more than half of patients had never heard of the concept of shared decision-making before. And almost 20% of health professionals had also never heard of shared decision-making. And as well as this knowledge gap, we also identified a practice gap. So this slide shows the steps involved in shared decision-making. This is based on the option instrument, which was developed and validated to measure the extent and quality of shared decision-making, and it outlines 12 key steps that should be part of that. The colour coding on the slide shows you how often patients and haematologists felt that these steps were happening in practice. So the yellow coding is where things are happening some of the time, the green coding is where it's happening all of the time, and the red coding is where it's never happening at all. And you can see that there's a discrepancy here between what haematologists feel is happening and what patients feel is happening. Haematologists are more optimistic about the steps being implemented. And you can see that for one step, patients felt that this was never happening. And this is the step about clinicians assessing from patients what the preferred approach to receiving information is, whether that's written information, verbal, whether it's directing them to leaflets or online support resources. Our research also looked at patients' preferred level of involvement alongside what their actual involvement had been. And this graph shows how they felt about their first consultation at diagnosis. So you can see the different categories of extremely involved, involved quite a bit, somewhat involved, a little bit, not at all. And the general message here is that patients are wanting to be more involved right from diagnosis than they were being involved. You can see that at diagnosis, 31% of patients want to be extremely involved, yet only 14% actually were. 17% reported no involvement at all, and there's only 2.5% of patients who preferred that level of involvement. So patients are arriving wanting a voice and not necessarily getting one. But it's also clear that there is variation in the level that patients want to be involved. We looked at how patients felt about their more recent consultation, and you can see that the gap does narrow. There's the patients who were actually extremely involved rises from 14% to 19%, which is closer to the 35% who wanted this level of involvement. So the trajectory is positive, but there's a substantial proportion of patients who are still less involved than they would like to be. So what might get in the way? Patients told us what they felt the barriers to them being involved in decision-making is. And you can see that the lack of knowledge and not understanding everything a health professional says was identified by around 2/3 of patients. And the good news is that these are things that can be overcome. Patients need to be offered information that's easy to understand, that's in their native language, and that's in a format that suits them, to allow them to have the opportunity to be an active partner in decision making. You can also see that around 4 out of 10 patients don't want to talk openly, don't want the responsibility, or feel too ill to be involved. And it's important to note that shared decision-making does not mean forcing involvement for every patient. It's about understanding where that patient sits on that spectrum at that moment and meeting them where they are. The other thing to say is that obviously preferences for involvement are not going to be fixed. They're likely to change over time and will evolve. Our research also asked health professionals what barriers they felt were important in terms of preventing the implementation of shared decision-making. And there's some specific challenges at the diagnosis point. So for many patients, this may be the first time they're hearing about myeloma. They may not know about shared decision-making. And there's also the emotional context, and patients may become emotionally overwhelmed. And health professionals may be feeling cautious about this context. They may not want to overload patients with information, or they may feel daunted about emotionally overwhelmed patients. The environment can also create some challenges for shared decision-making. Patients often identify haematology nurses as key figures for questions and for support, but this role is inconsistently available across Europe. And then a major concern is time and the constraints of consultation times being a barrier to meaningful shared decision-making. And our research highlighted that there are key decisions where a shared decision-making approach should be prioritised and is particularly helpful. This is when there are multiple treatment options for patients to consider, when there's therapies with potentially severe side effects, when there's therapy changes needed to be discussed because of side effects, because of progression, remission, or relapse. The decision around stopping treatment, including end-of-life care and palliative care decisions, the decisions around stem cell transplantations, and participation in clinical trials. So these are key moments where shared decision-making is particularly important. So in summary, implementation of shared decision-making is incomplete at even a fundamental level. There's a real practice gap between what haematologists think is happening and what patients are experiencing on the ground. And there's also this knowledge gap, even among health professionals. In general, patients are not as involved as they would like to be, and there are barriers towards shared decision-making. But many of these can be addressed, and it's too important not to routinely offer involvement to patients.
I would like now to introduce Dr. Monique Minima for her presentation regarding the accurate assessments, begin with conversations, tools and techniques in discussing treatment eligibility. Monique?
Before we start on the treatment options that newly diagnosed patients have, I would first like to say something about the new guidelines, European guidelines that were published and had some changes in the recent version. So these are the older guidelines from 2021. And here you can see that we still make the distinction between transplant-eligible patients and no transplant-eligible patients. And especially in the induction treatment, there are some changes. So the old guidelines said VRD or DARA VTD, and below and afterwards you see the level of evidence, and if that was not available, VTD or VCD, then still autologous stem cell transplantation and lenalidomide maintenance, while in the non-transplant eligible patients we have DARA RD, DARA VMP or VRD, and if that's not available, VMP or RD. But times are changing fastly in the myeloma field. So here you can see what's changed, especially in the first part. And now the new guidelines are out. They are published in the Nature. You see the reference below, Nature Reference Clinical Oncology in 2025. And nowadays we do advise a anti-CD38 monoclonal antibody combined with VRD. So it's DARA VRD or ISA VRD as a level 1A evidence. And if that's not available, DARA VTD. The stem cell transplantation is now followed if you don't give many induction cycles up front with consolidation therapy, and for high-risk patients, a tandem autologous stem cell transplantation should be considered. And the maintenance also changed a bit with DARA-R maintenance also now in the label. And in the transplant not eligible patients, also some studies came out, which will be discussed later on. But also there, the treatment changed a bit. ISA VRD, DARA VRD, and the DARA RD, while DARA VMP and VRD dropped a bit because of the results of the clinical trials that were done. So it's a lot to discuss with your patient, and perhaps, Elid, I can give your words to discuss what we all have to encounter these first steps when we are diagnosing a new patient with multiple myeloma.
Okay. So yeah, when discussing treatment eligibility, there's obviously a lot of information exchange needed, and this slide shows some of the critical elements of that. There's a lot of information that the clinician needs to establish, and patients are also likely to have many questions at this point as well. There's also going to be involvement of other health professionals and family members and carers as part of this discussion too. So it's a lot going on, and I'd ask the panel, how can we best manage treatment eligibility discussions?
Yeah, I must say that this is, of course, when we have guidelines, they help a lot. But in the end, like you stated in the beginning, every patient is different. So I must say that when I start, I try to give as much information, to have the information level as high as possible. But you also have to try to learn this patient. So you have to ask questions because not every patient is the same. And you also have to learn more about the medical situation of your patient, especially if you are going to advise an autologous stem cell transplantation, of course. So these are normally not done within one consultation, but I don't know if the other panelists have different views on this.
I agree with you that each patient is different, and it is important to have a knowledge regarding the background of the patient, the level of knowledge that he may have, the family of the patient, especially in Greece. Usually, there are other persons, relatives involved in the decision making also, and the discussions. So it depends, but I believe that the information the more the information that the patient will have, the better. And also sometimes I encourage them to ask me questions that they have searched through the internet, through AI, because they do it, and sometimes they often intimidated to bring this up. So I say it's okay. I mean, this is how reality is today. So if you have found some information and you want to discuss it, please do.
I must say that's a good one. I don't know how you're doing it, but there's so much information out there that I must admit I try to navigate that a bit. So I try to point them out to the official patient websites from my country or MPA or other acknowledged information sites, because there's a lot of out there, and if you don't navigate that a bit, sometimes they come back with not a good medical information.
So I can also comment on that. I think discussing transplant eligibility in this way is there's sort of two different things. One thing is a patient that is sort of where there is doubt about the medical eligibility because of comorbidities or age in the sort of upper limits and so on. That's one discussion. And then it's sort of it's medically can be difficult because we don't have any clear sort of evidence for where the limit goes. So in that situation, I think patient desire also plays a large role. Then you have the other situation where the patient is clearly transplant eligible, but there are still pros and cons of doing the transplant. So we see, I think we'll get back to that. We see that in the Norway registries, we see that within the same age population, transplant is going down. So we're doing it less also in transplantable patients where there's no medical problem, I think. So that's a different discussion again.
Yeah. I totally agree, and I do have a slide on transplant eligibility, and sometimes we are quite clear that this patient is eligible, but then the patient preferences can decide on a different way. So these are some of the criteria that are out there, but as you said, there's no uniform criteria. It's perhaps rather strange that one of the very much used treatment option, we don't have the same criteria everywhere. So of course, performance status, comorbidities, organ function, and liver and renal, that's much easier. We do that with laboratory, but respiratory function and echocardiography, I must admit, in the Netherlands, we don't do it standardly, so we only do it on indication. You see the patient before you and then you do it. And some X-rays and dental evaluation is something that we do as well, but it's done differently everywhere, and perhaps and I think it will remain like that. I don't think we will ever solve this problem uniformly. But the last one is age, and that's very interesting because I think we used to have an age limit of 65 years in the Netherlands. We changed that already more than 10 years ago to 70, but we do know that in other countries, especially in the US, they go above 70 years. So age is something that is perhaps not a strict cutoff. But if you look at some data, when patients are transplanted at an elderly age, you do see that the outcome, of course, these are selected patients, but the outcomes are not worse than in efficacy than in younger patients. So on your left, you see the Nordic patients is from a registry, so these are only transplanted patients. So they are selected people. But if you look at the age groups, you see 71 to 75 VGPR rates, but also survival rates do not differ that much from the younger population, and also from a US site, a single site retrospective data, smaller cohort, 125 patients, you clearly see that they transplanted up to 78 years old, and also their VGPR rates and survival rates do not seem to be worse. So perhaps we can transplant to an elderly age, but it's something that is not happening, of course, in all patients. We also have a frailty tool. This is the tool developed by IMWG. It's recommended to use, but it's especially used for elderly patients. So you see the tool up here. It's when you are below 75 years, on age you're only scoring a 0, but when you go up to 2, above 80 years, you have already a frailty score of 2, and then you are assessed as frail. And frailty scoring can be cumbersome, especially because of assessing HDL and instrumental HDL, and there are also some replacements, but this is something that can be used, perhaps not in a younger patient, but in elderly patients deciding if you want to go for stem cell transplantation. Perhaps this is a tool that you can use. A HOVON trial, so HOVON is the Dutch trial organization, did a trial in elderly patients, so not transplant-eligible patients. And what they clearly stated and found that if you are frail by age, so above 80 years old, your outcome is actually not that bad. It's better than if you're frail by impairments or ultra frail. So the age limit, again, is perhaps not the best cutoff to use to assess our patients' eligibility for treatment. And I think this is also said here, is that frailty is happening in our patients. It's important to assess that because they have a higher early mortality. They stop treatment earlier because of this toxicity. Some of the patients never go to second-line treatment. And frailty assessment in some way, how you do it in your hospital, remains important. And with that, I would like to thank you all and give the word back to Thanos.
Thank you, Monique, for your presentation. And now let's share with you and the colleagues some patient characteristics. So we have the first patient who is a 63-year-old female. She had persistent low back pain for 3 months and fatigue. The initial laboratory tests showed essentially a normal CBC. However, there was hypercalcemia, mild impairment of renal function, elevated LDH, and this led to a myeloma workup, which showed a monoclonal protein of 38 grams per liter, which was shown to be IgG kappa on immunofixation, a high FLC ratio of 120, high beta-2 macroglobulin, multiple lytic lesions, possible vertebral fracture. The bone marrow aspirate showed about 60% clonal plasma cells, and there were 2 adverse cytogenetic abnormalities, deletion 17p and 1q, placing the patient in clearly high risk according to the current IMWG criteria, and the revised ISS was 3. So this patient is transplant eligible clearly because of his age. He does not have significant comorbidities. Her performance status is adequate. Renal function is preserved, and also liver function is within normal limit. However, this patient, despite the fact that she is transplant eligible, despite the fact that she has high-risk features, she has some reservations about the idea of high-dose therapy. And at this point, I believe that good communication and shared decision-making are vital to achieve the best outcome for this patient. So, Frederick, how you would approach this patient? I mean, how will you present to her the characteristics of myeloma, the data that we have that this disease is unlikely to remain in response for a long period of time, and that in this particular condition, we believe that there is still a clear benefit for high-dose therapy, regardless of the response that the patient will achieve after induction.
Yeah, so first, I think that, as you mentioned lastly, that for these high-risk patients, we want to do a transplant because we think it benefits the patient. So that's my starting point. But I think to do a transplant leads inevitably to a bad condition afterwards in the sort of a short term. So when you have a patient that is reluctant to do that, it's important that she knows about this and agrees to it before. So this isn't, she needs to be really well informed about that period, because if she's reluctant but then convinced and then is not informed about what comes afterwards, she will not be happy with that. So secondly, I think patients are very different. Some patients are really scared of treatment, not so scared of the disease, scared of quality of life, or scared of a bad quality of life. And sometimes you need to really reinforce how dangerous the disease can be to make them really understand that. They have another category which is really treatment enthusiastic, and you then need to sort of focus on that there are side effects where it's important to think about quality of life. So I think one of the biggest skills you need in myeloma is to sense where the patient is and relate to that. And this patient is from this information in the first category, where she's focused more on the problems with the treatment than the problems with the disease. I think you really need to discuss with her the pros and cons. I think it's a possibility to not go for it if she really doesn't want it, but she needs to understand how the prognosis is in her situation and how the transplant with a mostly short-term problem can help her in the coming years. So I think in this case, I would probably, if needed, first I've told it, maybe showed her graphs if she is really unaware of how dangerous this disease can be. First that, but also focus on the possibility of treatment, both the transplant and what we can give in the next line. So, because it's also a signal that it's a balance. You need to understand that the disease is dangerous and we need to do the best we can, but also give some hope in the end that even with this bad prognosis, we still have many options later also. So I think that usually, I think we would end up by explaining this, that it will be possible to convince to a transplant, which I also think is the best thing to do here. I think also this discussion definitely is best if they have a partner, a next of kin with them. Discussions always get better, and the remembrance of what happened in the discussion also is better afterwards, I would say.
Yeah. Let me move to another case and then come back to Monique. So the second case, the second patient is an elderly patient, 82, with progressive fatigue over 4 months, thoracic back pain. The patient is anemic. He has a renal impairment, he has a monoclonal protein, he has a high FLC ratio, he has definite bone lesions, bone marrow infiltration, and the patient has a translocation of 14-16. As we know today, by itself, this translocation is not indicating high risk, and revised ISS stage 2. So the patient is 82, he's older, he doesn't have significant comorbidities, he has renal impairment and normal renal function. So, Monique, how you would approach this elderly but fit patient?
Yes. So an elderly but fit patient, I think the biggest discussion here is that how they want the treatment to be, and especially if we can add Velcade to their because I think it's obvious that this is not a patient for transplantation. So the daratumumab and the Revlimid and dexamethasone, I think, are key. But now with the new studies, do we add a proteasome inhibitor to this regimen, which can induce
38 based regimens with
yes, and I think one of the side effects, polyneuropathy, has to be discussed. And I don't know if this patient already had this, but I think that's a question that we all should ask our patient, because it's not that rare in 80 years old that they have some kind of neuropathy that you can increase with adding the proteasome inhibitor like Velcade. So, but I must also admit, if we don't have that much hurry, sometimes I send these patients also for geriatric assessment to a colleague, because assessing also mental function, the support function, walking test, how fit they are, is something that is not always easy for hematology. So I use a geriatric assessment done by a geriatric specialist to do this. And the home situation, I must say, it was not mentioned before, but especially when they're this age, sometimes they don't have a partner anymore. So children are very welcome to the conversation as well. But also the nurse specialist, they have a bit more time to talk to the patients about their home situation. Where do they live? How do they come to the hospital? And home treatment sometimes is much easier for them because they don't drive themselves anymore. So if you can, for example, have a treatment that can be given at home and not have to go once weekly to the hospital, that's also very important to them. So time restraint is something, Eli, that I also recognize. So I think the help of our nurses is very important, especially in the elderly patients.
Thank you very much. Let me go to the last patient. So this is a 70-year-old, so he's not too old. He has definite myeloma, renal impairment, high FLC ratio, and again, quite a bit of bone marrow infiltration, one cytogenetic abnormality, so the patient is not considered high risk according to our criteria. And in this particular patient, you go through the questionnaire and the past medical history, and you find out that despite looking good and not too old and walking easily, he has a history of diabetes. He has mild peripheral neuropathy. He had in the past an infarct, and he's taking multiple medications, and he has also a stent. His left ventricular ejection fraction is borderline 52. He has renal function impairment, which is significant, and normal liver function. So in the next minute, Frederick, how you would approach this patient who could be considered even transplant eligible, but the past medical history reveals all these issues. Would you give a quadruple or a triplet in this patient?
I would probably give a quadruplet. I think the question is whether to transplant or not. I think that we discussed transplant in the other situation, the high-risk patient. And I think that in patients that are... there's one thing we didn't talk about on transplant is that transplant in the two big transplant trials, not in quadruplets, in triplets, was a PFS benefit and not an OS benefit. And after those results, I think we have transplanted a bit less. We have been less eager to transplant anyone within the indication. So I think that's the first thing, whether to do a transplant or not. With the OS not being there, we have more or less stopped doing transplant over 70. We have stopped when it's sort of a doubt about the situation in the patient, and that's why we have seen a reduction in transplant in the whole under 70 population also. I just want to comment on what you said before. We have the frailty score and you have the geriatric assessment. So I don't believe so much in the frailty score. I think it's false positive and false negatives because we put in things that really doesn't matter. So I think to really know about this, you need to do this comprehensive thing, which is difficult to do in real world. So up front, I would think with these patients, a quadruplet when you're 70 and we're not giving a transplant. But I might miss some physical problems with the patient. And I think the comprehensive thing, we are doing a frail study now. We're doing more like gait function, how fast you can get up from a chair, a sort of strength, hand strength. Those kind of things says much that we don't actually do in the clinic. And I think that's where we're coming with this one. I think this is a patient where you could have started a quadruplet based on what we said before. But if we do these things, you might end up differently. So I think that's the considerations. And are you going to say more about this slide now?
I think we can move on. And,
because
in discussion, we will have more time to.
Okay, because I think the point was that this patient sort of discovered more frailty in these tests than we actually saw in the first place. Yeah.
Okay, so now it's your turn, Fredrik.
Yes, thank you. So I'm going to go through some treatment strategies in newly diagnosed myeloma in transplant-eligible and ineligible. So as Monique showed, the two options we have in frontline transplant-eligible patients, DARA-VRD and ISA-VRD. This is a Perseus trial, which is approved in Europe. So it's two continuous treatment groups. But with this DARA addition, we saw a large increase in PFS, large increase in MRD negativity. There's no overall survival signal yet, but it's very early when it comes to that. Not many patients have died in the study. So that became a standard in Europe, both in the induction consolidation phase and in the maintenance phase. The ISA-VRD study did it different. They had one randomization for the induction and one for the maintenance. So that study will read out later when it comes to maintenance to see how much the maintenance adds. But what is clear from this study is that the induction by itself, adding a CD38 antibody with isatuximab, increases MRD negativity a lot and increases PFS. So now we have two options for induction, but one option for maintenance in Europe. So as I mentioned, we have in 2020, transplant in Norway had already reduced to about 52%. In 2024, under 70. In 2024, it was down to 39%. So we see a continuous reduction in transplant in the patients under 70. I don't know, do you see that also?
No, I think in the Netherlands, we don't see that much. We see a constant around below 65. It's a constant 80%. So 20% are just, they have comorbidities or other problems or wishes that they are not transplanted. And actually the group below 65 to 70 years, that's around 40% of those patients are transplanted. So it's still there, it's the minority, and I don't think we will catch up also because it's already since 2013 that we do it in the Netherlands. But you can't transplant everybody, that's for sure. And 20% even below 65 is not transplanted in the Netherlands, and that's a stable factor.
So if you have a 55-year-old fit, no problems, would you transplant? Stand the risk?
Yes, we do transplant. Yes, because I feel like what you stated in the beginning, you know, it's a whole trajectory that a myeloma patient has to face. It's not only this procedure, but after the relapse, there will be another another treatment. So spanning all your options as long as possible is something that I try to talk to with our patients, that when it's not curable but very treatable, it means that you have to put your treatments in a very wise way. So autologous stem cell transplantation can be done now. Perhaps it can also be done in the relapse setting, that's true. but it can't be done when you're older. So 55 is quite young, so they have a large span.
Another point, if I may, is that we tend to look at median, but also we have to look at the tail of the curve. And so far, the majority of long-term disease-free survival patients that we have and we can identify from our databases are patients who had received high-dose therapy. So this is, I mean, I think the message should be that until now, high-dose therapy remains the standard for treatment of myeloma patients, and usually this treatment will work even better in standard risk patients by, giving them the opportunity for MRD, sustained MRD negativity.
But I think there's another consideration, because if you are below 60 or in your 40s or your 50s and you have a good prognosis, I think that the risk of secondary malignancies from transplant in the long run after 10-20 years is significant. And if you do get that when you're 55 versus getting that at 65, I think there might be a difference. I think in the younger patients where there's no high risk, I think that this is a discussion to take with the patient. Should we do the transplant now in frontline, or should we do it at relapse, which could be in 5 to 10 years? So I think that's worth discussing in patients that are not high risk and not expected to progress very, very soon. Yeah. If you're in your 60s to 70s, I see more the point of, if you don't do it now, you might never get it, and I think it's beneficial to get it. So I think that's also part of that.
So you don't believe very much in the cure prospect?
I do believe in the cure prospect.
Standard risk patients.
I believe for the transplant and the standard therapy, it's a small fraction. But I agree. That's part of the discussion, especially if you are use the quads and the DARA and maintenance, because that increases that cure rate with transplant probably more than without. Good. So we're moving on to transplant-ineligible. Very similar options. You have the same quads, ISA-VRD and DARA-VRD. The difference is that here you continue with the full schedule without bortezomib after 8 cycles. And you also have DARA-RD as an option there. This is based on the 2 studies, CEPHEUS and IMROS. CEPHEUS included deferred patients, so patients who could have been transplanted, and excluded the frail patients. A large PFS benefit, large MRD negativity benefit, and also had an 80-year limit. IMROS did not include the deferred patients and did not exclude the frail patients, so this population is a little bit more frail. But the results are quite similar. A large PFS benefit, a large benefit MRD negativity. Also here, there was an 80-year limit. In the guidelines, DARA-RD without the bortezomib is considered sort of the standard of care for frail patients. I think that's debatable. Because there are some other ways of sort of modifying this quads, and coming back to that. Just showing you here that since the IMROS trial did not exclude frail patients, we could evaluate the frail patients and how they did. And you see here in blue, ISA-VRD for non-frail and frail, and in gray, VRD for non-frail and frail. And you see the benefit is more or less the same. The distance between the gray curves is more or less the same as the distance between the blue curves. So the treatment worked similarly in the frail and in the non-frail. But remember, these patients were not over 80. This is that was PFS. This is overall survival, and we haven't seen overall survival benefit yet in these studies. But the readout is still too short for that, maybe. But there are ways of modifying these quads. So the standard for the transplant-ineligible is a quad with CD38 and VRD. There are two trials that have reduced this with very good results. One is a Nordic trial with a phase 2 one-arm trial where dexamethasone was removed after 2 cycles. Bortezomib was only given weekly for 8 cycles, and then there was continuation with ISA and LEN. And MRD negative CR rates are in a more frail and elderly population than in the Maya trial. It's higher than in the Maya trial. Maya trial was 25%. So it seems that adding this bortezomib gives more efficacy than you lose by removing dexamethasone. Otherwise, it's quite similar. And another study from the French group, this is only in frail patients. So you have the Cephalius imrus, not so frail, and you have Maya, more frail, the REST trial, even more frail, and this is only frail patients. Where you randomize between Lendex and Len-daratumab with dexamethasone in the 2 first cycles. And also here you see a large PFS benefit, a doubling, and a significant overall survival benefit. So I think adding CD38s instead of dexamethasone continuously leads to a longer life for these frail patients. So I think to start the discussion here, you have a quad, you have 4 drugs, and you have patients who get more and more frail, or you have a scale of frail patients. So Monique, what drugs do you remove first, and how do you start treatment? And
Monique, a quick answer, and then we can discuss it further.
Well, I think it's. I think the last trial did show it already. I think for elderly patients, DARA is hardly any problem. Lenalidomide less, but dexamethasone and bortezomib are the drugs that I should go for. So I make decisions. Bortezomib is always once weekly, and dexamethasone is also one of the drugs I do lower or stop very early on. Some of these patients have diabetes, so I think it's funny that dexamethasone is nowadays one of the most toxic drugs that we have in myeloma treatment.
Yeah, I agree. So Elid.
Yeah, so we're back to this two-way conversation that's needed, and this time about treatment selection. So how can we best have a two-way conversation around treatment selection?
Yeah, I think here we come a little bit back to what Monique started with. I think there are many options. I think for the transplant, it's sort of a package. But here you have 4 drugs, and they have different efficacy and different toxicity. I think if they are not fit based on whatever your clinical decision, or you do comprehensive geriatric score, I think we start removing drugs, and the first we remove is dexamethasone. I think it's the least important drug, it's the least efficacious drug, and it's also the most toxic drug for the elderly.
Actually, the single agent activity of high dose dexamethasone is 40%. So it's not so much efficacious, but I agree with you about his toxicity.
Yeah, and when you tested that versus a lower dose, it was better with a lower dose. Yeah.
In combination
when it comes to survival with Len, yeah. So I think that's the first one. The next one is bortezomib, and we almost base the bortezomib if they're not having neuropathy from before or are falling easily and those kind of things. We base it on sort of a simple thing that is this a person that should come to the hospital every week, or is this a person who mostly should stay at home with her next of kin? And if they are eager to get treatment, we discussed this. It's still only for a half a year with the bortezomib, but I think these patients is extremely necessary to be very proactively finding the neuropathy symptoms, because when they start, they will get worse. Then you need to stop in these patients. And the Len-dose is also something you can discuss. With the patients, do you want to start with a normal dose and have side effects and go down, or do you want to start lower and maybe consider, if it's not responding really well, going up?
Yeah, so we all agree that anti-CD38 monoclonal antibodies are the safest.
Yeah.
And, they have single agent activity, probably around 40%. We have this data from single agent studies. And, sometimes I found if the patient does not have neuropathy, that bortezomib may be better tolerated than lenalidomide in some, especially if you are more than 80. I agree with you that we have to take into consideration the possibility that lenalidomide may cause some asthenia and patient may feel, this mental fog sometimes. And so we all agree that this should be individualized for each particular patient. And it is very essential not to have discontinuation of therapy of side effects, because in these frail patients, this will be very difficult to restart.
And we have the other way to think is that if you look a bit surprisingly, if you look at the younger and the elderly, the relative survival of the elderly patients, they are losing more. They are losing more from myeloma than the younger patients from the registries. So it means that so efficacy-wise we are under-treating them, but so you need to find a balance where you both give a good treatment and not give too bad quality of life. So it can be difficult, these discussions.
Yeah, and in that sense, I always find it very important to reassure the patient that we start with a treatment, but it's not written in stone. So please stay on communication, tell about your side effects, because we can try to do something about it and lower the dose, but don't stop the treatment. Just communicate open. Yeah, that's very important message to give to our patients.
Yeah, because I think that's a good point, because with the elderly, I think what you start with is maybe not the most important thing. The important thing is how you follow it up.
Yes.
And I agree that to find a dose they're able to stay on is important.
And also to avoid relapse, because I think it's a good idea, if the patient has control of his myeloma, to maintain him on the best treatment that he can afford without side effects, and to avoid relapse, because in an 86-year-old patient, a relapse is quite difficult to control.
Yeah, and you have the attrition rate, which is much larger in the elderly, that they don't get to second line. So it's so if you undertreat, the patient might not get to the better options later. So with elderly, it's really a balance between these things, and you need to take the patient with you on that sort of discussion and journey with the pros and cons. And patients, especially elder patients, have even more diverging wishes for what is important for them than younger.
Yeah. Okay.
And how can we manage the role of other people in that conversation, the hematology nurses, but also the supporters around the patient, the family members who might be there?
I think that's always a difficult one. We do encourage, of course, that people come with the patient to the visit, to the HCP visit, and they can bring more people with them. I must say, we are trying now in the Netherlands some AI tools, so the conversation is recorded and then compromised, and then with some action points, and they can just send it out. So we normally see that the children of elderly patients, they put the phone on the table and they use some AI, and in the Netherlands that's totally allowed. If you don't spread it, keep it in your private atmosphere, and I think that helps a lot. But in the end, we can't service whole of the support group of or the caretakers of the patient. We can't talk to everybody, so it's a one person that you or partner that you talk to.
I saw a study that AIs were actually more empathetic than doctors. So maybe you should have the AI talk to the patient also.
Yes, we should develop that one.
Well, this is the last front that we have. If we lose empathy, then we're going to do. So, Ailey, maybe we can move on?
Yeah, sure. Okay. So a myeloma diagnosis obviously brings significant impact in terms of physical and emotional health impacts and impact on quality of life as well. And then the treatments for myeloma can bring further burden on top of this. The tasks involved in taking treatments might seem simple on their own, remembering to take tablets when instructed, arranging and attending medical appointments. But as the number of these tasks increases, so does the impact on daily life, family and work life as well. And a higher burden from treatment can lead to lower adherence, lower well-being for patients, and also lower satisfaction with treatment. So at MPE, we wanted to generate evidence about how patients feel about different treatment routes and locations. So we did an online survey that reached over 900 patients with myeloma across 22 countries. Our sample had a mean age of around 62, and we had a balanced distribution of gender, and you can see that we managed to reach around a quarter of our sample were from rural locations. So existing treatments for myeloma are intravenous, subcutaneous, with some oral treatments. And we asked our survey participants to rate the burden of treatments that they had direct experience of. And this slide shows the median burden score for different types of treatment. And what you can see is that the IV reported burden is nearly double that of oral treatment. But burden is not just one thing, and we asked patients to rate the burden of the different treatment modes in terms of the physical impact that it had on them, how the frequency of treatment impacted them, the efforts involved in taking the treatment as planned, any precautions that were needed around the treatment, the emotional impact, and the impact on daily activity, family life, and their finances. And from this, you can see the median burden scores here, and that was rated on a scale of 0 being no burden and 10 being considerable burden. And the most impacted domain for all treatment types is the daily activity burden. We also asked patients about their overall attitudes to different treatment types, and these may be treatments that they had experience of or may not have. And these are the median attitude scores for treatments at hospital. And this was rated on a score of 1 being wholly negative and 9 being wholly positive. And you can see the attitudes in our sample to treatments at hospital are broadly similar. The treatments requiring an inpatient stay are slightly more negative. And we also looked at whether having direct experience of treatment predicted patients' attitudes. And we found that for some treatment modalities, that lived experience did actually have a significant impact on the attitude scores. Patients who had experience of infusion, both inpatient and outpatient, actually scored this more negatively than patients who didn't have that direct experience. So there's indication that patients' attitudes towards different types may change with experience and are not likely to be fixed. They may change over time. We're seeing a broad shift in resources in Europe from acute in hospital to outpatient and in the community, and also home-based treatments have advanced in recent times. So we asked our patients their attitudes towards home-based treatments. And there are potential benefits to this type of treatment, as well as for the health system in terms of cost savings. There may be potential convenience, less burden for patients, but hospital-based care does bring comfort and reassurance to patients as well. They will be in the right place if anything goes wrong. And you can see that at-home treatment attitudes were very positive for oral treatment. That's the large blue one there, but more cautious around injectable treatments, especially when these are self or family or friend administered. So as healthcare systems push treatments towards home, we need to be aware that patients are not automatically on board, especially for injectable treatments. So there will be pros and cons of any treatment type, and decision making will of course factor significantly the efficacy and side effects of treatment. But we asked our patients in the survey to rate, aside from safety and efficacy, what were the most important attributes of treatment for them. And you can see here that the impact on day-to-day activity and the physical impact of treatment were the most important attitudes for our sample. But interestingly, the third most important attribute excuse me, was the chance to regularly see health professionals in person as they receive treatment. And this reflects the importance of that relationship with the healthcare team. Convenience is obviously important to patients, but moving treatment home without maintaining that contact is not what patients are asking for.
Several trials have compared the subcutaneous to the intravenous administration and the patient's attitudes to them. So we're going to look at a couple of them now. Several trials have looked at the comparison between subcutaneous and intravenous administration of isatuximab and daratumumab and the patient's attitudes to them. Now we're going to look at a couple of these trials. First, we have the Columba trial, which was with daratumumab. This was a large trial, 522 patients in the late-line approval of daratumumab, where they compared the subcutaneous and intravenous daratumumab on the common schedule of weekly, first for 2 cycles, and then bi-weekly for 4 cycles, and then every month. What we can see on the bottom left here is that the overall response was at least as good, maybe better with subcutaneous. So the maximum trough concentration the same, and the safety profile was similar. The fewer infusion reactions was seen with subcutaneous versus IV, with 13% versus 34%, and this led to daratumumab being approved as a subcutaneous treatment. The study also looked at patient satisfaction, and here we can see that on the question, how satisfied were you with your most recent cancer therapy going through the trial, you see that there's a continuous improvement in patient satisfactoriness with the subcutaneous version through the whole trial. Also for isatuximab, there's been this phase 3 trial with the goal of getting isatuximab subcutaneous approved. This was in the ISA-POMDEX approval, so patients with 1 previous line of therapy. Similarly sized trial. This was not a monotherapy trial. This was isatuximab pomalidomide dex with the subcutaneous in one arm and intravenous in the other arm. This was given in the standard schedule for isatuximab, with weekly the first cycles and then every other week until progression. Here you see similar results on the bottom left as with the daratumumab. You see also here that the overall response rate is at least as good, and the maximum trough concentration is also here higher. As expected, and what we saw in the trial was that there was a similar safety profile, except, as expected also, fewer infusion reactions with subcutaneous versus IV, with a 1.5% with sub-Q and 20% in the intravenous group. Also in this study, we looked at patient satisfaction, sort of different way to do it. This was a questionnaire. We can see here the main point here is that those who were satisfied or very satisfied with the treatment were 70% in the subcutaneous. And this was with the OBI, not with a subcutaneous injection, versus 53% with the intravenous. So I think putting these two studies together, it's very clear what we see, that the results are at least as good with subcutaneous for DARA and the OBI for isatuximab versus intravenous treatment with both drugs, and patients are more satisfied with this kind of administration.
So in summary, we need health professionals to be having transparent conversations that include discussing the mode of action, the frequency of treatment, the location of treatment, as well as eliciting patients' attitudes and priorities. And patients empowered with this knowledge can engage more meaningfully in shared decision making. It's important to not assume that at home means preferred. Patients are going to vary. And as novel treatment modes arrive, patients will need education and support to feel comfortable and confident in.
Thank you. So I will go relatively quickly through the last presentation so that we have time for discussion ourselves and with the colleagues. Going back to our cases, we have the first patient who is transplant eligible, but she has some reservation. What are the options if the patient continues to refuse high-dose therapy? What are the critical communication shared decision-making points in this case? I think we made the case for advocating and sort of insisting on high-dose therapy because she's high risk. Okay, Monique, in case she still refuses, what would be your treatment approach?
Well, if she refuses, of course, we try to understand why, but she still refuses.
Okay, yeah.
So we are going for a quadruplet, and I will try to keep the patient on the quadruplet as long as possible, and then after that, I will continue with DARA or lenalidomide maintenance because this is a high risk patient, and I think we should keep the patient on treatment.
Okay, Frederick.
In this patient, if she after 8 cycles tolerates bortezomib really well, I would try to convince her to stay on that. But
I would agree with that. So for this type of patient, one may consider what we call continuous treatment by using even 3 drugs at the doses that the patient can tolerate. Because of ultra high risk, I believe that it is helpful to have a PI also included in the sort of maintenance continuous treatment approach.
And one more important thing, I would try to convince her to at least harvest stem cells. Because if she relapses within a year, I think her approach might be
change.
Different. And then you need to have harvested the cells.
Great. Okay, good points. Okay, let's now move to the second patient. This patient is 82, but he's fit. He does not have comorbidities. And now, what are the treatment options? And okay, I will start saying that despite that we do not have data from IMROS or CEPHEUS trial for patients above the age of 80, in this particular type of patient, I would try to use a quadruple, maybe at adjusted doses of lenalidomide and, of course, weekly bortezomib, and try to discontinue dexamethasone as in the Nordic trial after a few courses of treatment. So your approach, Frederick and Monique?
I would do the same, just with weekly bortezomib.
Okay, Monique?
Yeah, I would also do the same, and but I think I hope that also with the geriatric assessment we will have some help in navigating this patient in the best way.
We take the assumption that he does not have any other comorbidities, but the age, which in the IMWG scale places him in the frailty condition.
And in the end,
he's above 80, and I believe this is not very correct. If you can have more than 80 without comorbidities, without medication, we have seen patients that take no pills. And
so I can mention that in the Nordic trial, 30% of the patients were over 80, and the quadruplet, but dexamethasone stoppage after 2 cycles, and most patients needed to reduce lenalidomide eventually. But we started with a full dose. I think for lenalidomide, the side effects are reversible. So if your dose is too high, you can just reduce.
Absolutely.
But if they tolerate it, you get the efficacy. But in most patients, you have to reduce.
That's a good point. Whereas, as you mentioned before, you want to avoid neuropathy from bortezomib, or identify it in early stages, because then it is not reversible, or it is reversible after many months or years.
Yeah, I want to make one critical point, because the studies did not investigate DRD versus DRVD. So in the end, we are making assumptions with cross-trial comparisons. That's of course all the data we have, but I think DRD is also still a valid option.
Of course, yes. Okay, so let's move now to the third patient, who apparently is a 70-year-old looking healthy patient, but has significant comorbidities, and he's taking many medications. So what are the potential treatment options for this patient? I will start with Frederick.
Yeah, as I mentioned before, I would probably start this with a quad also, but I think we are...
Quadruple as well.
Yeah. I think
he has diabetes for 15 years.
Yeah, so we would start with a very low dexamethasone and would skip that early. I think that's a good thing in most patients that
How about bortezomib and diabetes underlying neuropathy, which probably he will.
I just think the same, that I think it's okay to start with weekly, just be very sort of proactive on finding these symptoms. But I think if you have patients who walk very slowly to the office, and if they have in their history, have they fallen without any reason, that makes me more unsure about adding just a little bit of neuropathy. So I like to ask those questions.
Monique?
Yeah, I must say, I do know this thing that they stand up, they walk to you, and they give you a handshake, and that's the geriatric assessment. But I think that's not completely true, and I think polyneuropathy should be asked for. Many patients do not communicate that they are used to have this tingling in their feet and not walking, not able to walk anymore. So I think it should be in there. But also in this patient, I would not choose for autologous stem cell transplantation. I would perhaps not even start this discussion with this patient.
Let's say you don't have any more information. You have the information that we all have. Would you use a quadruple DAR-RD or DAR-R?
No, with this patient, I would start the quadruplet. Yes, with the information that we have, yes.
So we all agree that we want to use quadruple, but we are very cautious to, discontinue and or decrease the doses according to how the patient is progressing. Okay. There are two questions. If I can take those from A. I have one for Ailey. At many points during the cases, the panelists talked about their treatment recommendation, which was trying quadruples as long as possible, but how should this be discussed with patients? Do you have recommendations for how patients want to receive information, Ailey?
So patients will vary. There's not one way that will suit everybody. So asking the patient how they want to receive the information, whether they need leaflets, whether they need discussion, is really important. But the
and Monique brought up even more innovative approaches.
Yeah, that's true. But the transparency around the likely experience is really important to communicate, and communicating uncertainty in an honest way, I think, with patients really helps to build trust, and helps with patients feeling that they can trust their oncologist, and it helps with making decisions.
Yeah.
Now, a quite difficult question. I mean, in your countries that you have also some racial and cultural and religious, I wouldn't say minorities, I would say patients or individuals. I mean, would you take into consideration these factors when informing the patient about the nature of the disease, the severity of the disease, the expected outcome, or you have one-size-fits-all approach as you are addressing, a very, calm and strong Dutch man?
I must say that we do vision that from our ethical guidelines that every patient should receive every information possible. And we also have an electronic patient portals that they can see their own results. And so we are very, very open in that. We do sometimes hear that family is saying, no, don't bother my father or mother with this information about this disease and the nature of this disease, because that's too much for them. And I must say that's for us as physicians a very, very difficult issue, because normally we don't do that. So
you would force quote unquote information in a patient who does not want to?
Well, actually the patient is not saying anything. Family is deciding here. So that's, for me, that's the difficult one. If a patient is telling me herself or himself, that's how I want to be treated, then I respect that. But if family is deciding for a patient, then I always get a bit nervous, and I try to talk to the family again and again. It's not the way how we do it in the Netherlands.
Okay.
So to your question, I think there are, when it comes to sort of different minorities and religious backgrounds and so on, I think there might be sort of group differences, but I think the differences between individuals are much bigger. So I think it goes back to what we discussed before. I think I don't give the same information to all. There are, I think that's part of being a doctor, to try to understand what is important for this patient. And it will be, and there's always limits to the information you can give. We have tons of information. We have to sort of select what is the important information for this patient. I think that's one of the most important parts of the job we have, I think.
Yes, and building the trust that more information can be given, and just ask. Also, we now have this, like they can write us questions through their portal, and it won't be answered, of course, right away. But in a couple of days we can also order questions.
Question about the new OBI device. So okay,
You can take that first.
Okay, Frederick, since you have a significant experience on this device, could you describe how it is being used? And then we're coming back to microphone.
Yeah, so we had for some time now the intravenous isatuximab and the subcutaneous daratumumab. And many prefer the subcutaneous because it takes shorter time. But this OBI, which was approved in Europe last week with isatuximab, is a box. You open it, you put it on here, you press a button, and then within 7-8 minutes, it's injected. And this is really popular.
The drug comes in a device, and
the drug comes in a vial. So you put the vial on the box, and it's sucked up immediately. Then you put this box on the skin, and within 7-8 minutes, it pops out again. Then the injection is done. The needle is so thin they don't notice it.
Yeah.
And this is really popular among patients. And Sanofi has done studies where they switch from this or normal subcutaneous and the other way around. And this is much more popular. And that's also my impression.
Yeah. Because we have to clarify that the infusion rate is guided by the interstitial pressure. So it's usually between 7 to 12 minutes, depending on the individual. And it is automatic. I mean, it's not operator dependent at all. Yes, please.
Yes, sorry if I became later. Years ago, we have to discuss with Dr. Google, but now we had to discuss with a professor and master of medicine EA. How this is changing your discussion? You have to say, I don't believe that what you read in the EA. What is the problem? Because for us, it's very difficult to change the opinion.
If I may.
Because the family also is reading more than the patient, what the EA tell them.
Yeah, I think that in my practice, I do not go into dispute or controversy. I say, okay, what is the information that you got from AI? Most of the time is correct. Several times, there are some discrepancies. So I try as much as I can to discuss with them what they have identified. Quick answer, Monique, and then Frederick.
Yes, so that's obviously out there. I must say we don't have that problem that much, because it's also known that what you find on internet is not always the truth. So happily, in the Netherlands, trust in the doctor and the experience of the doctor and the training of a doctor is still quite good. So we always accept the information as well, put it out there. Then we try to say, well, this is an option, or sometimes they come up with options that are not reimbursed or not possible. So there are restrictions in what we can do, and I must say that's mostly accepted. So it's not a very big problem, but I work in an academic hospital, so we have some selection of patients there, and perhaps it's a more problem in your practice. But it's, I think we will have to make some leaflets, or some, not leaflets of course, but some information about how to deal with this, and that we can all use in our countries, because it will only increase.
1 minute, and I have another question, Frederick. 15 seconds.
Yeah, so I think it's important to acknowledge the things they find. It's the same with Google before and now with AI. I think it's better to discuss with patients that are informed. I think it's part of our job to understand and make them understand what they actually read, because it's not so easy to understand. And you have to accept and actually appreciate that they are informed more, but there are still things that are not there that you can explain them. But I like patients being Googling, and then we can discuss. It's more easy than to start on scratch, I think, actually.
I have a question from Fiona from Sydney, so I think we should take this one. Her question is, instead of de-escalating treatment, starting from a quadruple, how about starting with a lower doses, fewer agents, and then add if the patient tolerates? We start with Frederick and Monique.
In theory, that's good. I see that a lot in the sort of other hospitals. But what happens is that the monoclonal component goes down and they are happy. Not thinking about too much that this will lead to a shorter PFS. So I think the idea is good. In practice, the adding on and increasing therapy in patient-tolerated treatment is not happening.
Okay, Monique.
Yeah, I also think it's more difficult, gives more stress because you're adding, and then why are you adding? Is it not working? But also we do it a little bit in the Netherlands. We lower the dose of lenalidomide. Bortezomib is always given once weekly. Dexamethasone is lowered already in elderly patients. So we do have already some lowering of drugs, and we switch when it's not working. So it's already done there. But I also feel that starting with a better regimen and not adding drugs is more preferred.
Okay, I would like to thank you all. We're on time, and I believe we covered in this interesting satellite, a bit different from the usual one, things that matter to the patients. And I wish to all of you safe travels on your way back home. Thank you.
This has been an activity published by Peer Voice.